I need you to stop scrolling right now. What I'm about to share with you in the next 20 minutes could be the most important conversation you have about your brain this year. Because in nearly 3 decades of clinical practice, treating thousands of patients who walked into my office terrified that they were losing their minds, I have watched a single, quiet, almost invisible deficiency rob more good people of their memory, their balance, and their sense of self than almost any other condition I diagnose. And the most painful part, the part that keeps me writing, keeps me speaking, keeps me making videos like this one, is that most of their primary care physicians never even tested for it. Not once, not properly. I'm Dr. Evelyn Ashford. I'm a board certified neurologist. I completed my fellowship in cognitive disorders at Johns Hopkins. For the last 28 years, I've practiced at the Northeast Neurology Institute, where I specialize in age related neurodegenerative disease. I'm the author of 2 books on brain aging and cognitive longevity. And what I'm about to tell you is the kind of conversation I have with my patients in the exam room, and most people will never hear it. Number one on this list is something almost no one over 65 knows about. And a 2025 study from the University of California, San Francisco found something so disturbing about the way we currently test for it that it should change clinical practice in this country tomorrow. I'll give you everything you need by the end. Don't skip ahead. Stay with me, because by the end of this video, you'll understand what's actually happening inside your brain, why your standard blood panel is almost certainly missing it, and exactly what to ask your doctor for at your next appointment. Before we begin, I want to be clear. This content is for educational purposes only. It is not personalized medical advice. Nothing I share today is intended to diagnose, treat, or cure any disease. If you are taking medication, do not stop or change anything without speaking to your own physician. The information here is the result of decades of clinical observation and peer-reviewed research, but your health decisions belong with you and your doctor. Now, before we get into the list, I want you to do something for me. In the comments below, tell me your age and tell me one cognitive symptom you've noticed in the last 12 months, even a small one. Maybe it's losing words. Maybe it's a tingling sensation in your feet you've started ignoring. Maybe it's walking into the kitchen and forgetting why 3 times in a single afternoon. I read every comment on this channel, and the patterns I see in those answers shape every video I make. Take 10 seconds. It matters. Today, I'm going to walk you through 5 things, counting down, about the single most overlooked, most undertested, most misunderstood vitamin deficiency I see in patients who come to me with memory loss. By the end of this video, you will know more about this deficiency than the average general practitioner in this country, and I do not say that lightly. Let's begin. Number 5. Your standard blood test for this vitamin is, in my clinical opinion, dangerously outdated. In February of 2025, researchers at the University of California, San Francisco published a study in the journal Annals of Neurology that quietly upended 50 years of clinical thinking. They studied 231 healthy older adults, average age 71, none of whom had dementia, none of whom had mild cognitive impairment. Every single one of them had a vitamin B12 level inside what your laboratory calls the normal range. And yet, when these researchers looked at the participants with B12 levels at the lower end of normal, they found measurable damage to the white matter of the brain, those critical nerve fibers that allow different brain regions to communicate with each other. They found slower cognitive processing speeds. They found delayed visual signal conduction in the brain, which means the myelin sheath, the fatty insulation around the nerve cells, was already beginning to fail. Let me say that again. These were people whose lab reports said normal. The damage was happening anyway. The mechanism is this. Vitamin B12 is essential for the maintenance of myelin, and myelin is what allows electrical signals to travel through your nervous system at speed. When B12 is even subtly insufficient at the cellular level, those signals slow down. You feel it as brain fog, as word-finding trouble, as the sensation that you are thinking through fog. The current American reference range for B12 was set decades ago to detect a severe blood disorder called pernicious anemia, not to protect the brain. That is the gap. Number 5 is this. A normal B12 reading on your annual lab work does not mean your brain is getting what it needs. That's the science. But what comes next is the reason most physicians never catch this in time. Number 4. There is a far more sensitive test for B12 status, and your doctor almost certainly is not ordering it. It's called methylmalonic acid, or MMA. Here's what you need to understand. When B12 is doing its job inside your cells, it converts a compound called methylmalonyl-CoA into another compound the body can use for energy. When B12 is insufficient at the cellular level, even when serum B12 looks normal on a lab report, that conversion stalls and methylmalonic acid begins to accumulate in the blood. MMA rises before serum B12 falls. According to research summarized by the National Institutes of Health and Mayo Clinic laboratory standards, MMA is one of the most sensitive markers of early functional B12 deficiency, often elevated for months or years before any standard B12 test would flag a problem. Let me tell you about Eleanor. Eleanor was 72 when she came to my clinic, a retired English teacher, sharp her whole life. Her family had brought her in because she had begun losing words mid-sentence, repeating questions, and on 2 occasions had become disoriented, walking home from a grocery store she'd shopped at for 30 years. Her primary care physician had run a standard B12 test. The result was 412 picograms per milliliter, well within the so-called normal range. He told her gently that he was concerned about early Alzheimer's. When Eleanor came to me, the first test I ordered, alongside a full neurological workup, was methylmalonic acid. Hers came back at 680 nanomoles per liter, more than 2.5 times the upper limit of normal. We started her on methylcobalamin therapy, the active form of B12, and within 14 weeks, her cognitive test scores had improved by 22%. She is, as of last month, still teaching her grandchildren how to read. Her previous doctor was not a bad doctor. He simply did not know to look. That is number 4, demand the MMA test, or pair it with serum B12 and homocysteine. But the next item on this list explains why so many of you watching are at risk in the first place. Number 3, the deficiency is not always about what you eat. It's about what you cannot absorb. There are 3 medications more responsible for B12 depletion in older Americans than any other cause I see, and I want you to hear this clearly because I am not telling you to stop your medication. I am telling you to know what your medication is doing so that you can have an informed conversation with your prescribing physician. The first is the class of acid-suppressing drugs known as proton pump inhibitors. These are the medications people take, often for years, for reflux and heartburn. The mechanism is that B12 in food is bound to protein, and your stomach acid is what releases it so it can be absorbed in the small intestine. Suppress the acid for years, and you blunt that release. The second class is H2 blockers, which work by a similar mechanism. The third is metformin, the most widely prescribed medication for type 2 diabetes in the world. Metformin interferes with the calcium-dependent absorption of B12 in the terminal ileum. According to research published in journals including Diabetes Care and the World Journal of Diabetes, long-term metformin users can have B12 deficiency rates approaching 50%. Half. Let me tell you about James. James was 74. A retired engineer with type 2 diabetes, well controlled on metformin for 16 years. He'd also been on a proton pump inhibitor since his late 50s for chronic reflux. He came to me with what he described as cotton wool feet, increasing imbalance, and a vague but persistent fogginess that his wife had been worrying about for 2 years. His prior physician had attributed it to diabetic neuropathy and prescribed him another medication. I ordered MMA, homocysteine, and active B12. All 3 were abnormal. We worked together with his endocrinologist, and I underline that with his endocrinologist, to address the absorption issue, started high-dose oral methylcobalamin, and at his 6-month follow-up, his neuropathy symptoms had decreased by roughly 40% and his cognitive screening scores had risen meaningfully. James did not have early dementia. James had a treatable, reversible deficiency that had been missed for over a decade. That's number 3. If you are on these medications, you must be screened properly screened at least annually. And what comes next is the cellular biology that explains why the damage compounds. Number two, the brain damage caused by chronic B12 insufficiency is not psychological. It is structural. This is not theory. This is cellular biology. When B12 is insufficient, homocysteine, an amino acid byproduct of methylation, begins to rise in the blood. Elevated homocysteine is one of the most well-established modifiable risk factors for accelerated brain atrophy, vascular dementia, and Alzheimer's disease. The landmark VitaCog trial, conducted at the University of Oxford and published in 2010, randomized 271 older adults with mild cognitive impairment to either B vitamin therapy, including B12, or placebo. After 2 years, the rate of whole brain atrophy in the B vitamin group was 30% slower. In the participants with the highest homocysteine levels at baseline, the rate of atrophy was 53% slower. 53%. A subsequent paper showed that cognitive decline itself slowed in those same patients. We are not talking about a theoretical mechanism. We are talking about visible brain shrinkage caught on serial MRI scans, slowed in real time by correcting a deficiency. The neuroinflammation is real. The oxidative stress on neurons is real. The damage to the glymphatic system, the brain's waste-clearing pathway, is real. Let me tell you about Margaret. Margaret was 75, a widow. Came to me after 2 falls in 3 months and a slow onset cognitive decline her family had attributed to grief. Standard workup elsewhere had been unremarkable. Her serum B12 was 310, borderline by old standards, low normal by modern interpretation. Her homocysteine was 18.4 micromoles per liter, elevated. Her MRI showed early paraventricular white matter changes consistent with what we call small vessel disease. We initiated combined B12, B6, and folate therapy under careful supervision. At 12 months, her homocysteine had normalized to 9.1. Her gait was steadier. Her Montreal Cognitive Assessment score had risen from 22 to 26. Her family told me she had begun calling them by name again without hesitation. That is number 2. The damage is real, but in many cases it is also responsive. Which brings me finally to the most important item on this list. Let me pause for a moment. I know what you might be thinking. You're thinking I'm too far gone for this, or my memory is already declining. What difference does it make now? I want to tell you what I tell every patient who walks into my office at 70, 75, even 80. Your brain is not a fixed organ. It is plastic. It is responsive. It is, until your last day on Earth, capable of building new connections. The science is unambiguous on this point. The window does not close. The brain you have today is the brain you can still influence. Synaptic plasticity is not a metaphor. It is observable in laboratory imaging at every age. I have had patients in their late 70s recover cognitive function I would not have predicted possible if I had not seen it with my own eyes. The single most consistent factor I observe in those patients is that they began correcting their underlying biochemistry, and they began consistently. Not perfectly, consistently. If this is the kind of conversation you wish your own doctor would have with you, subscribe to this channel. I release new videos every week explaining the neuroscience behind the symptoms you've been told to ignore. Number 1. The most important thing you need to know, the thing that almost no patient over 65 has ever heard from a physician, is that the form of B12 you take if you decide to supplement matters profoundly. Not all B12 is equal. The cheapest, most common form on drugstore shelves is called cyanocobalamin. It is a synthetic form. Your body has to convert it into its active forms before it can be used in the brain. In some older adults, particularly those with reduced kidney function, certain genetic variations affecting methylation, and those with the malabsorption issues we discussed earlier, that conversion is impaired. The active forms are called methylcobalamin and adenosylcobalamin. Methylcobalamin is the form your nervous system actually uses to maintain myelin. Research compiled by groups at the National Institute on Aging and clinical observations across institutions including Mayo Clinic and Massachusetts General have increasingly suggested that for older adults with cognitive symptoms or neuropathy, the active forms are preferable. The protocol I have used in my own practice in patients who have been thoroughly evaluated and who are working with their primary physician typically begins with 1,000 micrograms of sublingual methylcobalamin taken daily for at least 8 to 12 weeks, with retesting of MMA and homocysteine to confirm cellular response. In patients with confirmed malabsorption, we sometimes work with a physician to use intramuscular injection therapy initially. But here is the part that matters most. Supplementation is not the first step. Testing is the first step, always. Because if you do not test, you do not know whether you are correcting a real deficiency or papering over a different problem entirely. Let me tell you about Patricia. Patricia was 66, recently retired, came in complaining of brain fog so severe she had stopped reading her beloved novels. Her serum B12 was 490. Looked fine. Her MMA was 390 nanomoles per liter, elevated. Her homocysteine was 16.2, elevated. We placed her on sublingual methylcobalamin, 1,000 micrograms daily with follow-up in 8 weeks. By week 10, her MMA had normalized. By week 16, she told me she had finished 3 books that month and remembered the plots of all of them. That is number 1. Test before you treat. Use the active form. Retest to confirm. And work with your physician throughout. Here is what I want you to take away from this conversation. Number 5, your standard B12 test almost certainly does not protect your brain at the level it needs to be protected. Number 4, methylmalonic acid testing is dramatically more sensitive, and you have every right to ask for it. Number 3, if you are on long-term acid suppression or metformin therapy, you are at substantially elevated risk and you need annual screening. Number 2, chronic B12 insufficiency contributes to measurable structural brain atrophy, but that process can in many cases be slowed and even partially reversed when corrected early. Number 1, the form, the dose, and the testing matter. Cyanocobalamin from a generic bottle is not the same intervention as targeted methylcobalamin therapy guided by repeat MMA testing. Here's what I want you to understand. Your brain doesn't know how old you are. It knows what signals you are sending it. Every meal, every walk, every hour of sleep, every breath. Whether you are 55 or 80, whether your mother had Alzheimer's or didn't, whether you felt sharp this morning or foggy, your brain retains a measurable, scientifically documented capacity to rebuild itself when you give it what it was designed to receive. B12 in the active form, in adequate cellular concentrations, is one of those things. It is not a miracle. It is not a cure. But for the patients I see whose deficiency goes unrecognized for years, the cost of missing it is enormous, and the cost of catching it is small. Don't let the size of the change overwhelm you. Pick one item from this list, just one. Do it tomorrow. Do it the day after. If it is calling your physician's office tomorrow morning and asking specifically for a methylmalonic acid test alongside your serum B12, do that. Consistency over 2 weeks is the single best predictor of long-term adoption. You don't need motivation. You need to start. All studies referenced in this video are linked in the description. Read them, print them, bring them to your next appointment. And in the comments, tell me which item you're starting first. I read every single one.